Hello friends, I am Dr. Vishnu Vinaykumar. I will be taking otorhinolaryngology and head and neck surgery for you. Otorhinolaryngology, what a powerful word, isn't it? If your neighboring auntie comes to you with vertigo and you tell her, Auntie, you have to see an otorhinolaryngologist, would she be terrified? So, no more terrifying words such as otorhinolaryngology for you. I would like to keep things as simple as ENT or ear, nose, throat. My aim of this series of lectures is to keep the concepts simple and clear for you so that you will be able to score the maximum marks in your theory exams as well as in your upcoming entrance exams. And I would like to start with the topic anatomy of external ear. Ear, as you know, consists of the external ear, middle ear and inner ear, and the encircled portion is the external ear, and as you can see there, it has got the pinna and external auditory canal as its parts. And pinna, it has been used for punishing you since your childhood, isn't it? And this pinna, they form fibrocartilaginous structures on the lateral surface of temporal bone, and it has got two surfaces, medial surface as well as lateral surface. If you palpate your own pinna, you can find that the lateral surface has got some prominences and depressions, whereas the medial surface has no such prominences. And the skin is very loose over the medial surface, whereas on the lateral surface it is tightly adherent to the underlying cartilage. The significance is that because of the subcutaneous tissue being more on the lateral surface, so the chance of perichondritis is more on the lateral surface. The subcutaneous tissue is less on the lateral surface, whereas subcutaneous tissue is more on the medial surface, and because of that it is very loose, and the chance of perichondritis is more when the lateral surface is involved. This you can confirm by palpating your own pinna. When you try to move the skin over the perichondrium or the lateral surface, you can see that it is difficult to move it over on the lateral surface, whereas on the medial surface it is very loose, and it is because of the subcutaneous tissue, and because of that the chance of perichondritis is more when the lateral surface of pinna is involved. Okay, this thing you have to be very clear, and as I said, there are some prominences and depressions that you have to be clear about, and for that I will be drawing it. Then you will be able to learn it by palpating your own pinna. Okay, so it starts with the helix. Helix has got a crus. Okay, and it then continues downwards like this. And yes, you got the antihelix, which splits into a superior and inferior limb. Antihelix splits into superior and inferior limb, and then there is an antitragus, and you have got a tragus. Okay, and this tragus is actually covering the external auditory meatus, which is the opening to the external auditory canal. Okay, this is the external auditory meatus, and you have the crus of helix here. Okay, and this is the ear lobule. Okay, so this is the tragus. Here you have the ear lobule. Now, ear lobule and incisura terminalis are the two areas in the pinna where there is no cartilage. Okay, in the incisura terminalis as well as in ear lobule there is no cartilage. So what is the significance? The significance is that when you have no cartilage, the chance of perichondritis to occur when there is injury is nil. Okay, no cartilage. So in the incisura terminalis you can put endoral incision without fearing perichondritis. And ear lobule, you can prick the ear. Okay, you can prick the ear. So that is the significance about that. And then there are some other landmarks that you have to know. Okay, just behind the tragus you have got a depression known as cavum congae. Okay, cavum congae. But you are more familiar with the other one, isn't it? The one which is seen below the antihelix and above the helix. What is that? Yes, that is Simba congae. Okay, Simba congae. Now the Simba congae, it has got its own significance. The Simba congae actually overlies the mastoid antrum. Okay, Simba congae overlies the mastoid antrum. What is this mastoid antrum? Mastoid antrum is the largest and most prominent mastoid air cell. Okay, and you will be learning about mastoid antrum and the mastoid air cells in the upcoming classes. For now, just know that Simba congae overlies the mastoid antrum, and here you have to elicit for mastoid tenderness. It is one of the three areas where you elicit for mastoid tenderness. Okay, Simba congae. And then you have also got the helix and antihelix. This is the helix, and here you have the antihelix. Okay, so these are the various parts of pinna that you have to be thorough about. Apart from that, there are two more areas. There is the triangular fossa that you see here. It is seen in between the two limbs of the antihelix, and the scaphoid fossa which is seen between the helix and the antihelix. Okay, but it's not that important. You have to remember the Simba congae very well, because it is the area where you elicit the mastoid tenderness. And then the incisura terminalis area, this space between the helix and the tragus, that is the incisura terminalis, where you put the endoral Lambert one part of endoral incision. Okay, so these are the things that you have to know in the anatomy of pinna. And yes, questions are usually asked from this area like this, that is skin or pinna is firm on both sides, loose on medial side, loose on lateral side, loose on both sides. This I already told you, that is pinna has got a lateral surface and a medial surface. On the lateral surface, it is tightly adherent to the underlying perichondrium, whereas on the medial surface it is loose and it has got subcutaneous tissue, so the chance of perichondritis is less. So the answer to this question is, it is loose on the medial surface, okay, and it is firm on the lateral surface. Okay, now that you have learned about the anatomy of pinna, let me come to the anatomy of external auditory canal. Okay, pinna, as I already told you, it consists of the fibrocartilaginous framework, isn't it? So the cartilage of the pinna, it continues as the cartilaginous part of external auditory canal, which is 8 mm in length. Okay, it continues as the cartilaginous external auditory canal, which is 8 mm in length, and then it forms the bony canal, which is 16 mm in length, 16 mm in length, to form the total length of external auditory canal as 24 mm. Okay, so this is 8 and here we have 24. Sorry, this is 16. Total it is 24. And this external auditory canal, the lateral 1/3, which is the cartilaginous external auditory canal, it is actually directed upwards, backwards and medially, whereas the bony external auditory canal is directed downwards, forwards and medially. Okay, this one is directed upwards, backwards and medially, this is directed downwards, forwards and medially. Now what is the significance of knowing this? When you have got the canal directed like this, if you have to see the tympanic membrane properly, you will have to pull the pinna upwards and backwards, because only then the external auditory canal, that is, this is, if you imagine this is the bony external auditory canal, it is directed downwards, forward and medially, whereas the other one is upwards, backwards and medially. So it will be at an angulation. Only if you are pulling the cartilaginous ESC upward, backward and medially like this, you will be able to see the tympanic membrane, because only then the external auditory canal will come in a straight line. Okay, and another thing is that the external auditory canal anterior and inferior walls are longer than the superior and the posterior walls. Okay, anterior and inferior walls are longer than superior and the posterior walls. Okay, so this is the cartilaginous external auditory canal. Now this cartilaginous external auditory canal is having a thicker skin than the bony external auditory canal, and also it has got hair follicles, so it will have hair like this. And apart from all this, it is also having ceruminous glands. Okay, ceruminous glands. What do these ceruminous glands secrete? Ceruminous glands are actually modified sweat glands, and they secrete wax or cerumen. And actually this wax is a mixture of cerumen and desquamated epithelium. Okay, and some people who are in seborrheic keratitis, they are more prone for wax formation and blocking of the external auditory canal. So on the lateral 1/3 you have got the hair follicles as well as the ceruminous glands. Okay, this is a ceruminous gland. And what is the significance of knowing this? The hair follicles being on the lateral side, the pharyngeal formation is seen only on the lateral 1/3. Okay, pharyngeal formation of the lateral 1/3 results in localized otitis externa, about which I will be telling in the next class. But for now, just remember that lateral 1/3 is the only area where there is hair follicles, and because of that, the chance of formation of pharyngeal due to folliculitis occurs only in the lateral 1/3. And this wax is seen all over the external auditory canal, but the production is seen only in the lateral 1/3, because ceruminous glands are seen only in the lateral 1/3. Okay, now you also have some fissures. Okay, fissures on the floor of the cartilaginous external auditory canal. What is that? It is the fissures of Santorini. Okay, fissures of Santorini. What are these fissures of Santorini? They are seen in the floor of ESC, and they help in the spread of infection from the external auditory canal to skull base as well as parotid. Why skull base? Because this external auditory canal is in fact a canal within the skull base. Okay, its roof and the floor is being formed by the skull base. And parotid, as you know, just behind the parotid gland you have the external auditory canal, isn't it? And it can easily spread into the parotid from the external auditory canal. Now, similar to these fissures of Santorini that you see here, you have got foramen in the bony ESC. Okay, so that is what is known as foramen of Hashke. Foramen of Hashke. And here you have the isthmus, which is the narrowest part. Now this term isthmus, which means the narrowest part of the external auditory canal, it is actually having a different word meaning. It is a narrow strip of land which connects two main lands. Okay, and it has always been used to indicate the narrowest area whenever an anatomy is described. In the usage tube also isthmus is there, and this isthmus is seen in the bony cartilaginous junction, unlike in the external auditory canal, as you have seen, where the isthmus is seen in the bony canal. And the antero-inferior part is widened like this soon after the isthmus. This area is what is known as the meatal recess. Okay, meatal recess. Now, if a foreign body gets lodged there, okay, if it gets lodged there, there is high chance of getting impacted, and in that case, you will have to do a posterior William Wild incision to remove the foreign body, because you won't be able to bring it out because of the isthmus. Okay, especially if it is a vegetable foreign body, there is high chance that it can get edematous because of the trauma. Any foreign body can cause trauma in the external auditory canal and can result in edema of the external auditory canal. All this can result in impaction. This vegetable foreign body, the thing is that it is hygroscopic in nature. If you are trying to remove it by syringing, it will swell up and it can get impacted. Anyway, the chance of impaction is more in the bony ESC because of the isthmus, which is a very narrow area, and anteroinferiorly you have the foramen of Hashke. Anteroinferiorly there is a meatal recess as well, which is a widening after the isthmus. And this foramen of Hashke, which is a fissure similar to fissures of Santorini, helps in spread of infection to skull base and parotid, just like the fissures of Santorini. I have been seeing this word Santorini a lot. You might have heard about Santorini somewhere else. Where is it? Yes, it is in the anatomy of the larynx. Okay, I'll be talking about anatomy of larynx in the coming classes. For now, remember that the corniculate cartilage is also known as Santorini cartilage. Okay, Santorini's cartilage. So that's why the term Santorini is important. Okay, if you are able to correlate like this, that is, if you are able to think about the other area where you learned about, then it will be easy for you to remember things. Okay, for example, if I say vestibule of the ear, okay, you might be thinking about vestibule of the nose as well, isn't it? You also have vestibule in the larynx. So in ENT, in the mouth also you have got another vestibule. So in ENT itself there are 4 vestibules, isn't it? So just like that, if you are able to think about the various areas, you might have heard the same name and correlate, that will help you in learning. Okay.